So a couple of days ago, I received the news that I have prostate cancer, which obviously has come as a bit of a shock. I had no symptoms that would indicate that I'm sick. And it's come about as a result of just having regular blood tests with my GP because I have a family history of it. But as a 49-year-old, I obviously wasn't expecting to get any kind of cancer this young in my life.
Yeah, look, 49 years old, healthy, enjoy sport, enjoy cycling, enjoying life. You don't think that this is going to happen to you. Since I was about 40, I was having regular sort of GP checkups for health and stuff, regular blood tests for the hereditary diseases my family have, which in my case, unfortunately, there's not that many. We have no history of really bad disease. The only things that we would really check for is diabetes, which my father's side has, and then on my mother's side there's prostate cancer.
Hi Darren, morning. Come in, take a seat.
Darren presented to his GP who performed a prostate blood test, particularly based on the fact that Darren had some family history of prostate cancer. This came back elevated, but in Darren's case, we had to take into the context that he did a lot of cycling. So sometimes when patients do a lot of cycling and they spend time on a hard saddle, it can push their PSA up a bit, and that could give a falsely elevated PSA. So in Darren's case, we repeated his PSA again after a couple of months, and we made sure that he did not cycle for at least 6 weeks.
Just a short to the ugly stand, please.
And when the PSA test was done the second time around, it was actually higher. So that rang alarm bells.
Gently pop a finger in.
Darren's prostate exam was normal, but because his PSA had risen,
All right.
I sent him for an MRI scan.
All done. And you can see here that the first lesion's at the left base.
He had 2 lesions in his prostate that were approximately 5 millimeters in size, and then we did an MRI fusion guided prostate biopsy where we did a 3D reconstruction of his prostate using the MRI.
Target these lesions here.
And then superimpose that onto his real-time ultrasound image of the prostate. We biopsied those lesions as well as the rest of the prostate.
That's good. All right. So let's do right apex now.
And in Darren's particular case, he had 1 out of the 36 samples that were taken that came positive for gleasonate high-grade prostate cancer.
And so the first targeted lesion at the base, you know, the one that I showed you on the MRI scan, that was the only one that came back positive.
It was bad news in the sense that Darren was diagnosed with prostate cancer, but it was also very lucky that we had this equipment available, that we were able to diagnose him, because I believe we've diagnosed him at an early stage where it has not progressed.
So what that means is that we would recommend active treatment for this because it is a clinically significant prostate cancer. It's called a Gleason 8 prostate cancer, and that puts you in a high-risk category.
There's definitely a male propensity to man up and just deal with stuff. I am actually an emotional person. I'll cry at a movie, you know, like that's fine. But when it comes to my own self, I guess I am a little bit stoic.
When you actually look at what I was talking about, which is the smaller lesions, we believe that doing it this way is more accurate.
Yeah. Okay.
You mention a high-grade cancer or even cancer, and I guess, you know, in my mind, the way it works is that it goes to worst-case scenario straight away. And even though I have knowledge about, you know, my uncle's got, you know, prostate cancer too, and so he's been having treatment for a while, and I've been talking to my auntie about that. So I have knowledge about prostate cancer. I know that it is very treatable. It still went to, oh my goodness, you know, could I lose my husband?
Okay. So we don't know for sure at this stage whether it's confined to the prostate.
The next steps would be to organise a staging scan, which is a PSMA PET scan. That's what we'd recommend.
After the prostate biopsy was done and we got the diagnosis of a gleasonate prostate cancer, we organised a PSMA PET scan for Darren, and we're quite fortunate in this country that we can offer this, because there's not many countries in the world that offer it apart from here, and I believe in Germany, and that's a highly sensitive staging scan which picks up any prostate cancer cells outside of the prostate. Thankfully, in Darren's case, his prostate cancer was confined to the prostate alone.
I have been feeling very anxious lately about removing the prostate, and the side effects of that being that I like to think that I'm a relatively young man, 49. Obviously not that young, but not that old. So yeah, taking the prostate out obviously has side effects. Certain nerves can be damaged, sexual function can be affected, continence can be affected. There is a recovery period of months to get those things back, and not a 100% certainty that they will come back the same as before. So that's a little bit worrying, but I have a good specialist, a good surgeon. I'm going for the latest technology in terms of surgery, so I'm giving myself the best chance. I'm trying to stay fit, positive, and happy as happy as you can be with a cancer diagnosis.
So generally most people are in hospital for a couple of nights, and then you go home with a catheter, which is a tube that drains your bladder, and then on day 7 we organise a cystogram.
The rationale for doing a radical prostatectomy, particularly in Darren's case, is a young man with high-risk prostate cancer. We've got a good chance to treat this with complete prostate removal. We generally don't remove a tumour in itself within the prostate. We go for complete cancer clearance, and hopefully once Darren's cancer's been removed and his PSA remains undetectable, then he will be cancer-free.
And that's the thing, it's like you get frustrated over small things, right? Like you'll be unable to find a decent car parking spot, or you'll have to you get a parking fine, or you'll have to spend some money on something that you didn't want to spend money on. Then things like this happen and you go, great, well, I was planning on having a party for my 50th. The thought of lying in my bed with a pee bag strapped to my leg on my 50th birthday is funny. Let's laugh about it. Good fun, good times.
Hey Darren, come on in, grab a seat. Okay, so your surgery is scheduled for about 2 weeks or so. So part of my job today is to go through this concept of pelvic floor muscle training. There are muscles that extend right the way through the pelvic floor, and some of them handle defecation, which is the passage of feces out of the body, and some of them handle urination. And because the removal of the prostate results in trauma to the front end of that system, there's no point in training muscles that are around the rear end. We want to target muscles that are specific to urination. Okay. So whereas a lot of times when you talk to men about muscles, instantaneously you can see them want to try and show you how strong they are. We're talking about how well you can hit a triple 20 on a dartboard. That's not strength, that's accuracy.
Right.
And so if we train for accuracy in the lead up to surgery, we can develop that and use that skill on the other side of surgery to develop the tissue.
Right, right.
I want you to think about 2 different sensations. This sensation of lifting your testicles vertically upwards from underneath you, as if you're walking into ice cold water.
Okay.
Just very, very softly scrunch. Good, good, and relax. Now what we saw on the screen there was this movement of this tissue in a backwards direction. Just try it again very slowly. Good, lovely, and then relax. And it's very much like you've got a natural over-enthusiastic schoolboy here that keeps trying to butt into the conversation that your brain is having with the muscles that specifically control urination.
Right.
So it's not important that you try and do it really hard or really fast. What's important is that you can separate those 2 sensations out.
Right.
The third vector is that penile shortening sensation. So not an anal squeezing or a testicular lifting, but imagine the penis is being shortened. And if I just hold my finger here, as you shorten the penis, we see this kind of rising wave of pressure from underneath, from over here. And the more you can get that feel, now remember, it's all well and good when you can see it on the screen, but you're going to have to go home and do this blindfold.
Right.
So it is actually very, very important that you get the benefit from looking at it now and get the feel for how gentle this really is.
Yeah. So what's this?
So we're trying to figure out the difference between your bottom moving in and your testicles moving up and your penis moving back. 3 different vectors of movement. Each one wants to be independently isolated as a contraction. See if you can hold it while you gently breathe in and out 2 or 3 times and then let go of that sensation.
Right.
And if we can practice that in the lead up to surgery, that's going to put you in a good position for us to then be able to develop more intensity when the muscle is at the right stage of healing on the other side of surgery.
Yeah.
So if you're going really well, I'll push you really hard. If you're not going so well, I'll hold you back a little bit.
Right.
But at the end of the day, we want to get you as close to dry and potent as we possibly can in the long term.
Fantastic. So it's about 4 days to my operation, and it's all starting to feel very real. I had my pre-admission clinic. I met the anaesthetist and my prostate cancer nurse and was basically heavily bombarded by her with a lot of information.
Right. So after surgery, you'll have a catheter. Have you had a catheter before?
I had one when I had my biopsy, yeah. This one's called the nuts and bolts of a prostatectomy. Nuts and bolts. But the funny thing about these articles is they're accompanied by ads like this one, which says, "Would you welcome a more discreet catheter?" Don't really know why that's even a question.
Yeah. So
We got into some interesting areas in the chat with the prostate cancer nurse, especially around the continence issues, the sexual function issues, and getting those back as quickly as possible.
you do need to self-stimulate 3 times a week. And
Can be an awkward conversation for some men. Maybe a male nurse might have been a little bit better for some people. I didn't really mind. She was very knowledgeable.
even the bladder is the flexible organ, it will have some sort of tension pulling back, so that can shrink your penis.
Obviously, the penile reconstruction is an issue for pretty much all men after prostate cancer. She suggested that I may need a penis pump for getting blood flow happening in the early stages, because the nerves obviously need blood going into them to recover, and that a penis pump helps there. And she showed me a very expensive one that the hospital recommends, but then said I could go into any sex shop and just get one off the shelf there, and that would do the job.
And that booklet is regarding your erectile dysfunction. This one's got
I've heard that the younger you are, the better. Hopefully erectile dysfunction won't be an issue for me, particularly as I've read all about it with this handy little erectile dysfunction notebook that I take to bed and read every night.
giving you a follow-up calls to see how you're going, how you're...
We talked about the operation itself, which is called robotic assisted laparoscopic radical prostatectomy, a RALP for short. So Ralph is having a RALP. Never thought I'd say that. Just having a few days up the coast with the family just to relax and try and, get my headspace right before the big day, which is this coming Thursday. So I'll keep you posted. Happy holidays.
Happy holidays.
I'm running with the storyline of the guys do this thousands of times. My surgeon is amazing. The technology is amazing. It should be fine. But I've seen some footage. They do, they go in there and they cut part of your body out and they take it out. It's what happens. So that is obviously scary.
So, time has come. Tomorrow is the surgery, so no looking back from here. Feeling pretty positive. I've had a shave. I'm ready to go. And yeah, I'll check in with you later on the other side.
Good morning, how are you?
Good. Darren Ralph for surgery today.
No problem.
So we're here at Chris O'Brien Lifehouse. I'm about to go and get a robot-assisted prostatectomy.
Pop into the bed and then just pull the blanket over the top of you once you're done.
Okay, awesome. I am mildly anxious about it.
I'll just do your blood pressure.
My long-term expectations are that my cancer will be removed
100% with the prostate, and I will live a long life.
Do you want normal?
Are you ready to take me down?
What we're going to do is, I'll just show you, we're going to make a few tiny incisions. We will be putting the robotic camera just above the belly button, and you'll have 3 other robotic arms, 1 on the left side and 2 on the right side. And then we'll have 2 assistant ports. One measures 10 millimeters up here, and the other measures 5 millimeters up on the other side. Okay. But we're going to shave up the area, and then once you start the operation, we'll put them all in, do the surgery. We'll give your wife a call at the beginning, and then we'll call her at the end as well to let her know how everything went.
Okay.
And then when you wake up, you'll have a tube that drains the bladder that's called a catheter.
Yeah.
Obviously that stays in for a week. Okay. And then I'll organise the test next week on Friday and just check everything's good, and we take it up then. All right.
I am now shitting myself, I have to say. I've got a little bit of shitty feeling in my stomach, but that's normal, right? They're going to put holes in me and snip me about and cut me up, so.
All right, I'll give you something to settle you down now. You may not remember much after I give you this.
Okay.
All right, good enough.
Right.
All right.
So the anaesthetist is just going to go and get me something to settle me down. I don't think it's a gin and tonic. I think it might be something a little bit stronger than that. So, looking forward to that. He did say I may not remember much after he's given it to me, so that's got to be good, right? Bring it on. Bring that on. I don't know where, where's the music? That's all I can say. First I was afraid I was petrified.
Yes.
Exactly my mood.
The robot that we use here is a Da Vinci Xi robot, so it's the latest robot, and it has an arm for a camera, and then it has 3 other separate arms that the surgeon controls. When the patient's anaesthetised, we then position the patient and check all their pressure points, and then we put all the ports in. So we get the camera port in first, and then we inflate the abdomen with carbon dioxide, and then we bring the robot in. We attach the camera arm of the robot to the camera port, which is within the patient. And then we attach the other 3 arms of the robot to the other 3 robotic ports. And then we also have another 2 assistant ports for the assistant surgeon, which he uses to place clips and use instruments and suck up any blood that's in the visual field. So we operate it sitting at a console, and often that console's perhaps 2 or 3 meters physically away from the robots. We look into the console. We have a 3D view of the camera of the insides of the patient, whereas the nurses and the assistants, when they're looking at the screens, are getting a 2D view. So that level of magnification is actually really helpful. The other things are the robotic instruments are wristed instruments, so they're different to standard laparoscopic instruments, and the wristing gives us 7 degrees of freedom, so they reflect the movement of the human wrist. The magnification together with the wristing of the robotic instruments enables us to operate in very tight spaces. We're just going to, probably in the next 20 minutes, start the nerve sparing part of the operation. So that's where we preserve the nerves to the neurovascular bundle, which is the nerves that supply the erections. We perform a neurovascular bundle sparing dissection. So there are 2 neurovascular bundles. Those nerves are predominantly responsible for erectile function, and we preserve them in this instance to help the patient gain their sexual function recovery. So once we've dissected the prostate away from all the surrounding structures, we then take the prostate and place it into an endocatch bag, which is then removed at the end of the surgery. So what we're doing now is we're just joining the bladder to the urethra, and that's called the anastomosis. The final step of the procedure is to use absorbable sutures who join the bladder neck to the urethra, and then we put the catheter into the bladder, inflate the balloon, and we do a test to make sure that the join is perfect and there's no leak, and then we basically finish the operation. So basically we've finished his operation. We're just checking all the ports and the sites where we put the ports in, just to make sure everything's good before we take the robot away, and then we're going to take the prostate out. Yeah. So this is the prostate that we put in the bag earlier on, and we've just removed it out through the camera port. This is where the area of the cancer was, and we've got gone a bit wider there. And these are the structures behind the prostate. That's the seminal vesicles, the vas deferens. This is the bladder neck, and this is where the tube that you pass the urine through. And you can see there when I put my instrument through, that's where the catheter is, and then that's the apex of the prostate, that's the base of the prostate. So we've taken that out now, and where the bladder was, we've sutured that very carefully to the urethra, which you saw during the surgery. I reconstructed the bladder neck, and then...
And what happens with that now?
So this now goes to the pathologist, and they'll slice it up, and they'll prepare slides, and then they'll look at it under the microscope, and they'll assess the margins of the cancer to make sure that everything's been completely clear during the surgery, which, from my impression of it, everything looked good, so I'm really positive that we get the pathologist to give us a final verdict.
Did really well, mate.
I didn't do anything.
You just laid there.
I just laid there, full of morphine.
Well, you did that well.
This part, but I don't remember any of this because he's given me a drug and I'm totally out of it, even though I'm awake.
Have you been concerned? Because I haven't spoken to you.
Yeah.
They don't care.
Well, it's just like we're concerned, but we know it'll be okay, so there's nothing much to worry about.
And we're just going to try our best and help a lot around the house.
That's very kind of you.
Oh, we got that on film. You realise that?
Okay.
There's no getting out of that now.
Yeah.
It's good to know that the equipment that we use now is like so advanced, and it's like, yeah. So there are lots of ways that they can get rid of it now, and it's a lot easier to handle them. So we're quite lucky that those types of equipments have been invented.
Well, lucky we live in this country, hey?
Yeah.
I have to record the amount of wee in my bag. So I'll just have a quick check. It's 300, so it's got to jot that down. 300 mils. So I can report to the nurse. Having a wee. Catheter style. It's about a midi, I reckon. 300 mils, isn't it?
285 for a midi, yeah.
285, just over a midi. All done. The joy of the catheter. So here we are, first day back home after my operation to get my cancerous prostate removed. I spent the best part of 3 days in hospital at the amazing Chris O'Brien Lifehouse, and I say truly amazing just because the level of care there is incredible.
Feel it? Just cold? Not stinking?
No, it's fine. And I feel thankful, grateful, blessed that I am living in 2020 and I got to experience that.
Happy?
Very happy. As wonderful as the hospital environment is at Chris O'Brien Lifehouse, it is lovely to be home with your family after such an ordeal. Sarah, do you want a cup of tea? The surgery, even though it is a keyhole robotic surgery, is quite invasive and there's a lot of pain afterwards, but that's so well managed. Got some great drugs. So there's 1, 2, 3, 4, 5, 6 little stab wounds. So currently wearing a catheter, which basically takes the urine directly out of my bladder. I don't have to go to the bathroom. I just have to empty it every now and again when it gets full. It's pretty discreet, you can't even see it, but I won't be venturing too far out of the house with that, rest assured. So there's that, and then obviously the next thing in my mind is the sexual function, although surprisingly at the moment, I'm not really thinking about that with the catheter attached to my nether regions. So I might have to update you on that in a couple of weeks when I actually start to think about those things. It's amazing what a turn off a catheter is. When I showed Trudy it for the first time, she was kind of a little bit shocked that what she saw is pretty confronting. So don't worry, I won't be showing you. So obviously sexual function is not really top of mind at present, but as soon as it is, I'll let you know. So, woken up this morning feeling a bit like it's Christmas Day. 2 reasons. Firstly, I got a call from my urologist yesterday, and he gave me the news that my prostate has been examined by the pathologist, and they have found no cancer outside of the prostate area. All indications are that I'm cancer free, so that's bloody good news. The second reason is today is the day I'm going for my cystogram, and that means hopefully my catheter will be removed. So I haven't shown you my catheter, I don't think. This is it. A little bag of pee that sits on my leg the whole time, which yes, is very fashionable. That's coming off today, so that's bloody great, because having a bag of pee tied to your leg the whole time is pretty weird.
So what we need to do is to see if your plumbing's all right.
Yes.
Before you get rid of your catheter.
Yeah, perfect. Dr. Dunn is going to inject purple dye up my catheter into my bladder, and they're going to basically photograph it to make sure that it's holding the liquid and not leaking. The other day, I fell asleep on the couch and probably urinated about 600 to 700 mils of urine over the course of a couple of hours. And by the time I'd woken up, it was straining at the seams so much that, look, the bag was actually compromised. It actually snapped off the elastic here. It was so full. I don't know what would happen if I'd have just kept sleeping. It would have just kept getting bigger and bigger and bigger, and then eventually exploded. But thankfully, we didn't get that far.
Okay, I'll just go grab the doctor.
Okay, thank you. See how the pictures come out now, and I'm sure the doctor will let me know the result.
It's been removed. We're looking for a leak over here. There isn't one. That's absolutely perfect. So he's going to get his catheter out.
The process now is to put a little pad in my undies because it's going to be a bit splashy. And yeah, then there's going to be a moment where the tube is being pulled out of my willy, which may hurt or may not. I'm assured there's a 20% chance of a wincy face.
I find slow is more comfortable.
Yeah, it's very...
It's gone.
That was amazingly easy. Wow.
This is the object.
It's been inside my bladder for a week. Amazing. Does that get recycled?
No. The next stage is actually the worst bit.
Oh, really?
Quick week.
Ah, that's good.
He's a free man.
Back sack and crack wax done.
How'd that feel? Was that all right?
That was good. That was actually the most painful part. He was right.
So, after I had my catheter out, the whole issue of continence became very real, or incontinence. So, as soon as it came out, I was on my own. The bladder, I hadn't used my bladder for a week, and then I had to drink water, and they had to test my bladder to make sure I could actually empty it properly. So what they do is they make you drink pretty much a few glasses of water and then wait. And then when you feel like you need to pee, you pee, and then they look at your bladder and make sure it's actually empty with an ultrasound. So I did this twice. I really didn't feel the same sensations that I had before my surgery of having a full bladder. So what actually happened was that you start to sort of wee involuntarily and you think, well, this must be it. So I went and weed, but I only weed a small amount. So they measured my bladder and it actually emptied. So that was good. So they actually let me go. But I only had a very small pad in my underwear. So I decided to stupidly go to the train station and not wait for Trudy to pick me up. And that caused me a lot of distress because within about 50 metres of the train station, my bladder decided to empty involuntarily, and the pad in my underwear literally filled within about 30 seconds. So I scrambled into the Strathfield train station toilet. Luckily I had a full man nappy in my bag, so I got that out and was able to get unchanged and put that on, but not without spraying pee everywhere all over my shorts and t-shirt because my penis was like out of a dry hosepipe. So that was very, very humiliating. And sitting on the train on the way home, the day before my birthday felt a little bit disappointing. So subsequently, next day, didn't bother going out for my birthday, spent my 50th birthday wearing one of these, sitting at home.
Happy birthday to you! Woo-hoo!
I just peed my pants.
So an important part of recovering from prostate cancer is the post-surgery physio. That's all about regaining continence, basically, and also giving yourself the best chance of getting good sexual function back after prostate cancer surgery. So we had a little joke about it.
Really, every morning in the shower, you want to be playing with your willy like a 10-year-old boy or 13-year-old boy. And that's the kind of thing that we want to do to encourage that blood movement.
An important part of recovering continence is recording the data from your pads, which is also very strange. So literally every time you use a pad, you're supposed to weigh it and then record, basically, list the weight of each pad, and hopefully, if you're making progress, the pad weight should just get lower and lower and lower each time.
As you've modified your activity levels and you slow down a little bit, we see this improvement in terms of your 24-hour pad weight score.
I'm finding that it's a bit up and down. It is trending lower, but it's not always lower every day. You have good days, you have bad days. Then he took me through the post-surgery rehabilitation program, which is quite intense. There's a lot of exercises you have to do for speed and strength. He took me through all that, which was very interesting.
As you blow out, start to squeeze. Blow out, squeeze, 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 crescendo to a maximum effort and then release and let go. The key thing is each time you do a breath out and squeeze, we want you to get a new PB in terms of the intensity.
Yeah, it gave me a really good written program that I have been sticking to as much as possible.
Yeah. But you've got to just pace yourself a little bit. All right. So, okay.
Before the surgery, you hear about this stuff and you read about this stuff, but when you actually experience it on the other side, you experience the incontinence, you experience the impotency, it's very, very confronting and very isolating.
So sexual function will be impacted with any type of treatment, and in particular surgery will have an effect on it. And what you will find is that immediately after surgery you will experience likely loss of erections, and that can last for several months. But generally it usually recovers to around 70 to 80% of your normal preoperative state with the use of tablets and potentially injections.
So there's a chance it could be better than 70%?
Look, there is.
That's just data.
Absolutely there is a chance it could be better than that, but we prefer to give you a realistic expectation. So if we set ourselves a target of around that level, then it's going to be a realistic expectation.
Okay, that's quite confronting.
It's because it's a sexual organ, there's a degree of embarrassment and there's a degree of reticence in relation to potential emasculation, and so they are scared, they're vulnerable, and they don't necessarily want to ask all these questions. So I often find that the guys who talk a bit more, particularly with their partner, are mentally more prepared for what to expect afterwards.
And that took me a while to understand as well. I didn't realise how focused men were, even my own husband, on on everything that's happening down there and the importance of sex and, in our life and what's going to happen afterwards. And I think that to him was the hardest part. What's going to happen after I have this surgery? Is it going to, mean that I won't be able to have sex and, what could happen. That was really a big focus.
So the last sort of couple of weeks I've been really thinking about the sexual health and recovering my sexual function. I've purchased one of these little beauties, which is a penis pump. So apparently you can get these in a sex shop, but I was a little bit embarrassed to go into a sex shop. And also I heard that these ones are specialist medical versions that you get online, and they're actually much better quality and work really well. So what you do is you basically pop your old sausage in there, put the lid on like this, screw this down tight, and you just put a little bit of gel in here, a little bit of lube, and then you pop it on, and then you pump, and basically create a vacuum here, and that just draws all the blood into your penis, and it becomes engorged with blood, and you kind of get an erection. So that is actually amazing, considering that I have felt nothing. It's post-surgery, so this apparently you use a couple times a day, and it speeds up your recovery and ensures that all the nerve bundles are working and everything. So that'll be a fun thing to do a couple of times a day. A little bit weird, but hey, got to do what you got to do. I started back at work, which is great. I wanted to sort of start getting back into normal life. I'm not allowed to ride my bike, so I've got to take public transport. And of course I'm still wearing pads, so that's a little bit strange, but not as strange as wearing a nappy. So that's good. You have good days and bad days. And it really does depend on how the strain you do. You kind of got to stay focused and remember to engage the muscles. Hey everybody! I find the hard thing is not drinking alcohol. I've been pretty good most of the time, but for my mental health, I've had to, definitely had to have a drink every now and again. Otherwise I think I'd go insane. Here there'll be like food and plated like antidepressants. In my head, I was going to have surgery, and then I was going to go back to work after 6 weeks, and everything was going to be fine. That is not the case. I'm on a path here that could take 2 years. I'm aware of that now. May even be longer, and there may be things that have changed about me forever. So I've kind of just trying to get in that headspace of that's my new reality. Okay, big week this week. I've just been to the local pathology clinic at my doctor's and got a blood test, which is going to basically look for PSA in my blood, and hopefully it'll be undetectable. So basically, if that is undetectable, that means I'm cancer-free. I won't know until Thursday when I have a consultation with my specialist, with Ruben, but double fingers crossed, I have undetectable PSA and I get an all clear on Thursday.
All right, yeah, good. Take a seat. Thank you. All right, Ralphie, we've got some great news for you. Your PSA is back, and as you can see here, it's undetectable. Which is fantastic. Amazing. So that's the result that you did a couple of days ago. That's excellent news. Yeah, so that's fantastic. So it's come back as less than 0.01. You can't get a better result than that.
Oh, that's amazing news. Oh, thanks so much.
So I'm really pleased to see that Darren's had a great result. We've discussed his prostate cancer specimen at the Lifehouse Prostate Cancer Multidisciplinary Meeting, and this showed that all of his cancer's been removed, and in addition to that he's had his first post-operative PSA blood test, and thankfully that has come back undetectable. So from a cancer point of view, an oncological surgery point of view, we couldn't have hoped for a better result.
I didn't realise so many men got prostate cancer, but it usually happens when you're a lot older. Luckily, we've caught it at a really good stage to catch it and get rid of, the danger of it happening again. So I would just say, know your family history, get tested. Early detection is key.
There's more to life than being continent and having great sex, but those things are obviously very important for most people. Yeah, I just hope that I get those things back, and if those things come back, 90% of how they were before, then I'm winning, I think. And the plus side is I'm going to live a long life. My hereditary disease is hopefully gone, and I'm going to have to make sure I have lots of superannuation saved up because I'm going to live till I'm 100.